In this short lecture, I would like to share my experience of managing various dissecting lesions of the intracranial VA, although my experience is rather limited. As Dr. Mitsutani classified, intracranial VA dissection may show diverse features with various clinical presentations such as self-limiting headaches, infarction, or even subarachnoid hemorrhage. Treatment options are available like this slide, from the medical management, deconstructive, reconstructive, and vascular treatment to surgical treatment. However, it could be quite sophisticated and sometimes tricky. I think that is why I'm giving this lecture. We know that there could not be a single straightforward management strategy since the condition is complex and the outcome could be unpredictable. In the treatment planning, there are several factors to consider, from the clinical presentation to the mass effect from the aneurysm, etc. Let's begin with a ruptured dissection case. 40-year-old man presented with a massive SAH, especially in the posterior fossa. Subsequent CTA showed fusiform dilatation of the left distal VA. On angiography, brisk extravasation of contrast media was seen. He had a rather good right VA and intact pica origin here. We decided to trap the fusiform lesion here. The decision was done right away in this particular case. In performing the trapping, there are several factors to consider other than the patency and the size of the contralateral VA, especially when the cortical branch is originating from the dissected segment. We should consider OA pica bypass surgery if the branch is big. We need to keep in mind that the bypass does not guarantee good cerebellar perfusion because of the potential vasospasm. Of course, we can consider reconstructive approach such as stent assist coiling or flow diversion, even though it could not be completely secure. Another big issue is sparing the lateral medullary perforator. It may originate directly from the VA or pica. Careful scrutinization of the 3D angiography would be helpful in the avoidance of any sizable branch occlusion. I trapped the segment with coils. I tried to minimize the trap length as short as possible. After that, the patient was managed in usual post-SAH protocol. The case says that the trapping would be the best and the durable treatment only if we can spare the branches. Reconstructive treatment could be the second option, especially when trapping seemed unfavorable. Don't forget the potential hidden enemy, which is vasospasm. Other than rupture, acute presentation could be mild, such as posterior neck pain. However, diverse neurologic symptoms and signs could be seen in case of combined infarction due to various mechanisms. If there is no hemorrhage, antithrombotic management should be initiated. What is important in this situation is close image monitoring of the acutely dissected lesion, as this case. 40-year-old man presented with severe neck pain. His initial MRA finding was like this: poor visualization of the left distal VA without any infarction. Since his symptom was gradually relieved with pain management, he visited our hospital and the follow-up imaging was done 10 days after initial imaging. Marked change of the image findings was seen. Poor visualization of both distal VAs. This is the initial MRA. Subsequent high-resolution MR imaging showed severe stenosis and dilatation of both VAs. Even though the patient was clinically stable, angiographic findings were striking. A typical dissecting aneurysm of the right distal VA was noted, showing stenosis, aneurysm formation, and the distal occlusion here. He had a rather good ipsilateral PCOM artery, filling most of the vaginal territory like this. Left VA flow was severely diminished, only to fill dissected aneurysm here. I think this kind of dynamic changes are not uncommon in distal VA dissections. The next day, we called the patient back. Antegrade distal VA flow is decreased further. We decided to place a self-expanding stent into the pica. However, the aneurysm was still there like this. We did both stenting and additional coiling like this. Right pica flow was seen on the TOF MRA obtained the next day, while left VA was not visible. CTA was obtained about 3 months later. While right pica was seen well like this, we found that the aneurysm in the left distal VA had come again. Follow-up DSA after 3 months since then showed full recanalization of the previously occluded right distal VA connection to the basilar artery. However, the aneurysm in the left distal VA was seen more clearly. Different from the lesion in the right distal VA, what bothered me was the unusual course of the ipsilateral pica origin. I thought that left pica could be filled not via the true lumen, but via the false lumen together with the aneurysmal component. I thought that cannulation of the collapsed true lumen could be tried if we can navigate from above. After bilateral VA access, I tried like this, maybe via this course. Unfortunately, it wasn't successful. I'm quite sure that if we tried in acute phase, when the pica was seen faintly with a small aneurysm, then the attempt could be successful. We stopped the procedure here since I didn't like to rupture the artery. Then what can we do for him as of now? While both the patient and doctor were indecisive, another 6 months has passed. The aneurysm was there like this. This time, we sent the patient for surgery, direct clipping, and bypass. The case says unilateral dissection may not stay as unilateral. Simple dissection may change into aneurysmal lesions. Rapid change of its feature by spontaneous occlusion and recanalization may hide underlying dissecting lesions. Many points or issues remain unanswered yet. Another case, 48-year-old man presented with left pica territorial infarction and a prominent aneurysmal lesion. We put the patient on antiplatelets. DSA revealed atypical findings of partially thrombosed fusiform aneurysm like this. High-resolution MR confirmed the impression. After 6 months, the lesion was still there, with further filling of the sag and increased irregularity of the involved segment. In this situation, flow diversion would be the right choice as of now. Since the device was not available then, we did loose coiling and overlapped LVS stents. This is the 18 months follow-up MRA finding. I think this is still viable treatment option together with the flow diversion for this kind of lesion. This is an incidental fusiform aneurysm in a 45-year-old man. Treat or not treat. We did overlapped stenting with the neuroform stents. Not surprisingly, there was no response on 6 months follow-up, and 3 years, 6 years, and even 9 years. Neuroforms were not effective, but the aneurysm seems stable on long-term follow-up. It seems like close observation could also be a good management option in this kind of lesion. There could be no argument on the treatment indication of this kind of aneurysm. Flow diversion was planned even though there was an acute angulation at the distal landing zone. We covered the angled segment with sufficient length using a 35mm device. This was MRA obtained the next day. The patient was fine and discharged. On 3 months follow, to my disappointment, the aneurysm was there like this. That was due to shortening of the device like this. When we reviewed the MRA obtained post-op day 1, we found that we neglected the displaced device. For those 3 months, the device had been floating in the aneurysm sac. We called the patient right away for another telescoping device placement like this. Migration and shortening may occur more frequently in the vertebro-basilar junction. We need to be careful in the image interpretation, and I would like to recommend earlier imaging follow-up. With this, I would like to summarize my talk. Due to the unique nature of the anatomy, distal intradural VA dissection may show versatile features in the clinical and the imaging presentations. We need to be careful in the interpretation of the image findings, even for the normal-looking segments. Compared to other arterial dissection, shorter interval imaging follow-ups are recommended. Various endovascular treatment options are available. However, there remains many unclear issues needed to be explored further. Thank you for your attention.